thank you all for attending. It should be fun to be able to exchange knowledge, and your experience is going to be different than mine, so it'll be really fun to do lots of interaction. As from my first slide that you can see there, I'll give you a little bit of background about the telehealth that I have been doing in British Columbia, and then my most recent project working with Indigenous communities and developing a community-led type of telehealth process. So there's only about 15, 20 slides. So, and again, if you do have questions, please ask away, for sure. This is meant to be kind of informal. So my background too, I should let you know, is I'm a third-generation settler in Canada, with grandparents and great-grandparents from Scotland and Ireland. I'm a wife and a mother of 3. I have 6 beautiful grandchildren, one of whom has Cree heritage. And I'm an auntie, and very lucky to be working in the unceded territory of the Syilx Nation in British Columbia. I used to be a basic scientist. I was a biochemist, but then I saw the light and decided I wanted to care for people rather than test tubes. So I went into medicine at a slightly older age with 3 children, which maybe some of you have done, and eventually went on to become an endocrinologist. I've been doing telehealth one way or the other, starting in Calgary, Alberta, since about 2010 or so, and have been in British Columbia since 2012. So going forward, I'd like to acknowledge the local people, the Mana, Whenua, Ki, Waitaha, and let you know where in Canada we are. Most of you probably know this, but I find some people like to kind of get centered, is where am I from? So this is British Columbia, and you've probably all heard of Vancouver, and over here, Toronto. I'm presuming you can see my, my arrow here. Where I come from is actually a small town, well, city, in British Columbia called Kelowna. We're located on our university, University of British Columbia in the Okanagan, is located on a rather large lake. And here's us, City Park Beach in the summer, quite a resort area. It's a 128-kilometer lake. And we also boast probably 150 vineyards around the Okanagan Valley. So having just been to your beautiful Marlborough district, I thought, oh, I better show this slide of our beautiful lake, our hills. I wouldn't call them mountains, our hills, and some of our beautiful grapes. We have a winter. We actually get snow as well. We have temperatures in the summer of 40 degrees, but in the winter we can actually get snow. So we have quite a variable climate. And our wee medical school is only 10 years old, and this is the Reichwald Health Sciences Center. And I'm very proud to be married to the associate dean who created this medical school, and we have graduated our 6th class. So this is kind of setting the stage for, I'm operating out of a fairly small town. So our little medical school is part of the big system of University of British Columbia. So in Vancouver, that big city on that was on your left, they have 180 students or so, and there's we're called the Southern Medical Program. We only have 32 students per year, and then there's an island medical school on Victoria Island, and in the north of BC, another small medical school of 32 students, but we're all part of the UBC system. Little bit on telehealth in BC. Now, all this data, I'm not sure in New Zealand, I think you probably keep better data than us, but the last data we have, yeah, because, well, it just changes from day to day. But back in about 2015, when this data was available in British Columbia alone, there was over 900 video locations in 270 settings and 117 remote communities in the BC and Yukon, including First Nations communities. I'm pretty sure that by now is probably double, but that's what I had. And with respect to what I'll be talking about later about telehealth with Indigenous communities, I think you've been through this process also, thinking, well, Indigenous communities are not going to be interested in telehealth. But in fact, in talking with people from the various communities, the elders welcome telehealth to improve and expand access to care locally and to build on local assets, including local professionals, traditional knowledge, and traditional medicine and family members. Taking that into account, that's how we're going to develop the community-led telehealth center. IH is Interior Health. It should be IHA, actually. That's our health authority. So we have across Canada, we have federal funding and then provincial funding for health authorities, and each province will have several different health authorities. And I'm not sure if you have health boards here, but it's something like the UK health boards. And as of January 2017, they had 174 sites, which I think is probably an underestimation. Also, and I'm probably you have this here, is the growing number of private online and telehealth services. I've noticed we have them, but you can walk by a pharmacy and sign in and get a physician interaction online. So I have no way of knowing how rapidly that's growing, but it'll be interesting to see if you have that sort of thing. Another important aspect is how physicians are paid and how other healthcare providers are paid. Physicians and nurse practitioners can bill fee for service or obtain sessional fees. So sessional fees means like a salary, $133 an hour for a 3.5-hour clinic or something like that. Nurse practitioners can bill the government just as I do as a physician. So I think that aspect, that support has improved dramatically. So in terms of Indigenous telehealth, this isn't in British Columbia, but this was great. And perhaps having spoken to Andrew, this is antiquated, but these kind of robots that, this is in Pelican Narrows, which is a very small area in Saskatchewan, where they have this robot, and of course there's the physician in the middle. I guess I can do this. There's the physician in the middle, but in the robot is ultrasound, electrocardiogram, ophthalmoscope, otoscope, dermatoscope. So it has, pretty much a physician's office on the robot. And unfortunately, my particular system is underfunded, so we don't have that. But I think maybe you probably do have some of that. So I'll go back to about 2012, 2013 when I arrived in British Columbia. There was one other endocrinologist in town who had a waiting list of a year. And I said, I'm not going to be doing that. I will do something else for British Columbia, and that is to set up diabetes telehealth. So that involved partnerships, of course, with Interior Health Authority. So that's our health authority. And they provide a lot of the technology, the Polycom Real Presence software, and the tech help. Doctors of BC is one of our physician organizations that support practice. Shared Care Partners for Patient and Division of Family Practice. So a lot of partnerships around the people who would be using the facility. And we started off in the Interior Health. So this is a little portion of British Columbia, and this is Interior Health, so the borders of our health authority that I work within. Just as an aside, from province to province in Canada, one physician can't practice and live in one province and see patients in another province. And I don't know if that is the same here in New Zealand. So that's something that we're working on, so that, yes, if I happen to have a slot open, I should be able to see a patient in Quebec or, you know, the other side of the country. If needed, that patient needs to be seen. So that's an aside. But here's where we started originally. And I guess I need my glasses to see what I've got here. I started with just a few areas: Kamloops, Merritt, and Kelowna itself. Because our local endocrinologist had such a long waiting list, I started to see patients from my telehealth clinic. Also, background on that is, given that I was starting something new, I was happy I had a salary from UBC to do research and teach and administer the student research project, because the first 2 or 3 years of setting up a new telehealth clinic were pretty sparse in terms of income. So in order to cut costs, I would do my telehealth clinics from my own home office in my home, which was great. And I would telehealth into diabetes centers. So starting with those 2 centers, we really got the system up and going, and Interior Health understood the process. So over those years, just to keep this short, we've now expanded to include that other endocrinologist in town, and also a GP diabetes specialist. And this is a young lady. I call her a young lady. She's almost my age, but she is an amazing GP, and her diabetes has always been her passion. And she's on the Canadian Diabetes Guidelines Committee and writes half the chapters. So she has joined our clinic. So we're up now to 3, which is not a lot. But in Vancouver, a bunch of physicians now are getting, endocrinologists are getting together to do more diabetes. But in Interior Health now, we've expanded over the last 3 years to the 3 doctors, and then we have several rural sites that we're working with. So moving from that is in discussions with some of our local Indigenous communities, and based on some previous research, it became clear to me and my Métis colleague who she's a nurse, PhD nurse, and we do research together, and it became clear that some of the local Indigenous communities were interested in telehealth. They didn't have access one way or the other to medical care. Some of those communities are just like New Zealand and Australia. They're way out there. It's a 12-hour drive to the nearest, well, specialist, maybe a flight away, not even a drive. And there's also interesting phenomenon. About 60 to 80% of our Indigenous people in British Columbia live off reserve and don't feel comfortable accessing the Western health system, but also are unable to access the system on the reserves. So they have limited access in general. So during part of a research project entitled, and it's a CIHR, which is one of our major funding agencies in Canada, we had a project that's ongoing now for another 3 or 4 years, building Indigenous pathways for diabetes and obesity prevention and management with urban rural communities in BC. So these would be the Indigenous communities that are in the gap. They can't access our system or won't, and don't feel comfortable either, or can't access the Indigenous system. So we formed partnerships with the community, with the university and the health authority. Unfortunately, there is an Indigenous specific health authority called First Nations Health Authority, and they have signed an agreement with the Interior Health Authority, the Ministry of Health, and the nations, the Indigenous nations, to take care of everyone. And because of these jurisdictional challenges, that's not happening. So this project was set within the communities, is community driven, to determine what were the community's priorities. There are 6 communities we're working with. A couple of them are actually in Kelowna, and then the other 4 are getting rural, and some are quite remote. 1 road into the town, and that's it. And so
how big a population would those communities have? Would they be, you know, just a few hundred
they would
people,
be maybe, yeah, 3,000 people maybe, including the surrounding. The town itself would be 150 maybe. So some of them are very, very small. Some are a little bit bigger.
What about the infrastructure? How is the rural infrastructure?
The infrastructure is within the kind of town or medical center, because even some of the smallest ones have a medical center that might have 3 or 4 doctors. So it's not that super, super remote. They actually will have internet. And so being able to Skype in, Polycom in would work very well. Interior Health Authority has made an extreme effort to make sure there's providers available for, say, a diabetes center. So there's nurse practitioners or certified diabetes educators, which are nurses or dietitians that are able to do smaller adjustments and support the GPs in their work. Is that what you were hoping to hear?
Yeah, especially about the internet technology. Thanks. I was also just wondering about the model. Is the model to other health centres or community centres, or is it into patients' homes?
Yes. So we're evolving in British Columbia. We're very slow, actually. In Alberta, we've for years developed these primary care centres where there would be physicians, psychiatrists, dentists, physios, social workers, etc. British Columbia is starting to evolve into those kind of centers. But in these small communities, they often don't have the capacity to do that. So each of the GP associations are working towards that sort of thing, and it's happening in the big cities. And I think in Kelowna, for example, I think the groups we're working with, the Indigenous groups we're working with, are working out of friendship centers, and a friendship center and a Métis center. And it looks like one of these primary healthcare centers is actually going to provide a nurse practitioner, 0.5 of a nurse practitioner to each of these friendship centers, which is pretty exciting. In terms, I think I heard you say access to home care, or maybe I didn't hear that.
Access to homes. So instead of from the specialist into another centre, actually into people's homes.
Yeah, good question. Yeah, so that is not going on as much as I suspect it's going on here, and well, of course, I'm making a lot of assumptions one way or the other, but that's something with remote monitoring, you know, those kinds of things. And that was going to be one of my questions of all of you is, you know, how are you doing with that remote monitoring and going into the house and, you know, discharging a patient from hospital and being able to follow them up at home would be ideal. Certainly with the system that we have in BC right now, at least it's a local diabetes center. But with this new Indigenous initiative I'll talk about in a second, we're moving it out of healthcare center and into friendship center and Métis center. And I think once the communities are comfortable with that, then can start moving it into homes. In the really remote communities, though, they don't really have internet connection. So I've spoken to a few of those community members, and they say, well, I still have to drive 12 hours just to get to the remote diabetes center. So for that, we have mobile diabetes centers, like you have your mobile surgical unit and your mobile lithotripsy. We have mobile diabetes centers that will go around to these communities, but it's not usually ongoing care. It's not that, you know, they'll do some monitoring and a bit of education, but what happens, you know, when the hemoglobin A1C needs to be done 3 months later, you know, it's the follow-up isn't always the best. Although I've had a few referrals from that team, so that's a start. But I think that moving into the homes is got to be the next thing, and the kind of virtual connection is going to be the challenge, and that's where Andrew comes in with all his expertise and how we have a system to a cell phone that you know, that is fairly private, etc. And how do we get a cell phone to some of these people who can't afford it? And then how do we connect with those people that don't have internet? So a lot of questions, although I guess use of satellite is starting to help us with that. We've certainly had that problem in some of the northern communities in Canada where the population is sparse too, but so is the internet. So it was important with this community, that sort of the kind of isolated community. They may be living in the middle of the city of Kelowna or in these small areas that don't have access. So we used what we call Indigenous methodologies, and that's participatory methodologies, where we would sit with community members in talking circles. During community gatherings, we would get feedback. We used some questionnaires, focus groups, and interviews to find out what were their health priorities, what's going on in your lives, and let us know what you want to do. And so they did identify the priorities, and I'll show you the next slide in a minute. But while we were doing all this, we were lucky enough to be funded well enough to hire community advisory teams and community research coordinators. So of course they were from the Indigenous community. The advisory teams had elders, traditional healers, community members, and also included the executive directors, for example, from the friendship centers, which are like a local community center, and the research coordinator. And a lot of training goes on with the research coordinator, who then transmits information to the community advisory teams, who consult the community on what they want and how they want to do it. And so it's very, really as much as an equal partnership as we can get. And so through these kind of mechanisms, and these are the Friendship and Métis Center areas that we dealt with, and these are each of their special logos. And these are the kinds of things kinds of priorities the communities identified: health education, cultural safety, community belonging and learning, food security and nutrition education, traditional healing, and then of course access to care. And the word telehealth or telemedicine came up amongst the community members. And it was at that time, once I heard that, I said, well, gee, I have the capacity. I work with Interior Health, for that one part of the partnership. I'm working with the communities. Let's start a community-led Indigenous telehealth project. In the meantime, our CIHR funding with the other project was dealing with health education, traditional healing, and community belonging and learning together. And what each community now, to this date, they've put on community-led programs. And they have put on 3 sessions. So each program in each community is around 6 to 8 or 9 weeks. and then there's a break, and then they put on another one. So they're just in March going to be finishing up their third in each. Now I can't believe it, but each of the 6 communities are finishing their third program. And the program would go for 2 hours a week. 1 hour was a traditional healer or an elder or a traditional activity, ceremony, beading, dance, drumming. So some kind of traditional activity. And then the second was an interactive educational session. And we got feedback from the individuals in the community as to what they wanted to learn about. Like, what do you want to learn about? You know, we could go off on what we think they need to know, but they told us what they needed to know. I've done some of the interactive sessions by video conferencing, and it's not quite as good as person to person, but so much webinar and video education goes on, the community members found it okay. They enjoyed it. It was better than nothing, better than not having it. And of course, so few of them actually have really seen a specialist ever before. So that's, again, the benefit of video conferencing and telehealth. And I made sure that each community, either in person, so the communities that are close to where I live, that I could drive to, and I've driven to all of them, had a face-to-face interaction with myself, so they got to know me. There's another endocrinologist working with me. I brought him too with our grant funding to meet the community, so they were comfortable, and introduced the telehealth concept to each of the communities and community members. And this was the kind of diagram I used. Most people had Skyped, and that was my first question: have you ever Skyped? And of course, a lot of them said, yes, I have. And so I said, this is just really like Skyping. And what you have is a diabetes physician on one end, and then you on the other end with a support person or by yourself or a family member. And in our case, we'll have some kind of health provider support for the patient on the other end. And the location traditionally has been diabetes centers, as I mentioned, but we want to hold this in their comfort zone. So in the Friendship Center and Métis Center. And eventually, as you questioned, home. We would like to be able to do that at home. And in terms of the diabetes physician, well, I'll talk about that in a minute. So these were the questions that we asked the community members. What would make an obesity and diabetes telehealth program or appointment safe and comfortable for elders and family members? And then how can we bring traditional healers and elders and knowledge keepers to this program? How do you do that in a sustainable way? Because we don't pay traditional healers. And the community members really felt it so important that health is holistic, and it's spiritual, mental, emotional, and physical. And so bringing a traditional healer into that physical Western model would hold credence and feel culturally safe to these folks. So they told us, well, of course, privacy is huge, private room, family or friend would accompany them, and they would feel most comfortable with an Indigenous physician. Trusted local health provider, ideally Indigenous, traditional healer or elder, and they favored, well, I shouldn't say favored, they said private would be great, but also group sessions. And a lot of the community members thought that peer learning was really important. Some community members, on the other hand, feel stilted and don't want to speak up, or, you know, kind of feel insecure saying, you know, say my hemoglobin A1C is not very good, kind of thing. But that was what the community told us. Some would want just private, and that's wonderful, absolutely wonderful. So in making sure that all the community visits occur, and a lot of this work is ongoing. When I get back from my sabbatical, I will be visiting each of the communities for 2 or 3 days. We've already introduced the technology, and we've actually piloted it in one Friendship Center and one Métis Center in Kelowna itself. I bought 4 laptop computers with a little camera, trying to keep all the technology really cheap and simple. And Interior Health has been very supportive of that. And each of the community research coordinators was in on the session, so they're trained up front. And as I mentioned, working with the health authority to make the software and IT component as simple as possible and provide ongoing support. As you well know, technology is not perfect, and you can be in the middle of a session and something crashes. So they're always available, which is really, Andrew's shaking his head, yeah, or nodding. Yeah, he's been there, done that. And we provide health provider education. I say RN, RD, and nurse practitioner, but also MDs. If they want help and support, that's got to be there, because if it's not easy, it's not going to happen unless the provider has experience. And then if these clinics are going to be taking place outside the traditional healthcare setting, then into these Métis and Friendship Centers, then we have to go over step by step what's going to happen in a clinic. They're not used to holding clinics. They hold programs, but not clinics. And so I meet with the research, or the executive director and research coordinator of each of these centers, and we go over exactly what needs to happen. And they tell me how that's going to be done, or if it's going to be done. And in each center, there's got to be a champion or two. Because if there isn't a champion, it's not going to happen. So I will again renew their commitment to making this happen. And I think the key is to start off slow and grow with time. And then, of course, just as we would evaluate a program, you need input from all the users. So while engaging with the RNs, dietitians and nurse practitioners, the local GPs. So I'll spend time meeting with as many of the local GPs as I can to get them to understand the process. How about Indigenous physicians? I think you may be like us. You don't have a lot of Indigenous physicians, such valuable people. And our school graduates 1 to 2 each year. University of British Columbia, probably, I think last year there was 11 Indigenous physicians that were graduated. So we were really, really thrilled. And what we've done so far with this particular program is I contacted one of our graduates who I'd taught, and I asked him, he just started practice in a town south of Kelowna, and would he be interested in this, in participating? And he said yes. I contacted another young lady, and she was very interested. So I asked them too, and would they value a workshop, interactive, face-to-face, webinar, video, whatever, on becoming a diabetes expert? In other words, here's the key things you need to know to be really useful in terms of the diabetes. Just a step up, much like that GP that we have who's a diabetes expert. And they were very keen on that. So we're in the process of developing a workshop. We're pretty much completed because I'm getting input from our other endocrinologists. We also have an Indigenous physician in Northern Alberta who does telehealth to her on reserve communities. So we went up to visit with her and watched her do a telehealth clinic, and she's had a lot of input into this. And she would love to become more of a diabetes expert. So it will be a diabetes and obesity workshop, and preferably Indigenous physicians, but I think it's probably impossible to just have Indigenous physicians, but time will tell, and it takes a long time. The course, the workshop, I have students working on this while I'm here on getting accreditation. So in Canada, I'm sure the same is here. Each year, physicians have to get so many educational points to maintain their practice and their license. So we will make sure that this is a fully accredited course, and I probably will apply for funding from our licensing agencies to support and fund the physicians to take this course. And I also will apply for sessional rates for the physicians until the clinics fill up a bit. I also have recommended that perhaps while physicians are doing, say, a walk-in clinic, they could be doing the telehealth in between walk-in clinic patients. That would be another way financially to maintain, find income. And also, one of the key things in Canada, for me as a specialist to see a patient, I have to get a GP referral in order to get paid specialist fees, which are more than what a GP makes. And that's a whole other area of contention. If we are lucky enough to train up enough GPs, then we're in a situation where a patient can self-refer. They don't need a GP because not all our patients have GPs. About 25% of our community members, Indigenous or otherwise, don't have a family physician. So unlike your system where really everybody's kind of registered and cared for, but there's always a few out there that aren't. And in our case, it's around 25% of people. So these folks will still have access to diabetes expertise. And so that opens up a whole other area. And I think that's where our health authority is really actually going to love it. And until we can get a system where all patients are registered, then this might be helpful. And yeah, the GP referral. So how we're doing referrals and scheduling, well, certainly if a GP wants a patient seen, then they put in a referral to the telehealth unit or to the physician itself or themselves, and they can be faxed or a letter. What we need is a universal online system where referrals and scheduling can occur. Plunk referrals and scheduling and then conferencing all into one would be ideal. What we do have an online booking system, which is really nice. It's simple, and there's a calendar kind of thing. It's really ABCs, and there's a calendar with a page for each of the physicians, and healthcare providers or the physician itself can plug in the appointment. And usually by the end of a telehealth appointment with a patient, it's either me or the nurse practitioner or nurse or dietitian that's filling in the follow-up appointment. So it's done, and the patient's given a written little note on it. Not perfect, because we know people forget, but that at least patient leaves with their next appointment. And in terms of electronic medical records, then again, that needs to be automated a little bit more, but throughout interior health, we do have several EMRs, and that's another thing that needs to be totally universal. The same system needs to be universal, and I think that that's a challenge across Canada, and sounds like here you might be on the verge of having a consistent system. And I think what's blocking us is the fact that we have these separate provinces that have big walls between them, and whereas you're a country and you're a together country. So but certainly the visit is entered into the EMR, and a note is sent to the family doctor about what happened at the appointment. So I think that we kind of talked about this running a clinic appointment with the help of the patient or the diabetes team or both. Then you decide how the appointment's going to run. You know, are you going to call in when the patient arrives? Is the patient going to be by themselves? Or are they going to be with a nurse or a dietitian? Or are you going to have the nurse dietitian or nurse practitioner see the patient first, get all the background data, and call in afterwards? And that's what I used to do, because it meant I could see 2 or 3 patients in the time that it would take for me to collect all the data. So that seemed to work out well. And it also meant that the patient got a good relationship going with the provider on the other end, which was good. And then fitting patients in between face-to-face clinic patients works. And what I would do is set aside a day, and I'm sure most people do, and then I would flip from site to site. With our online booking schedule, that was easy. And the way I ran a day would be I would take telephone consults from 7 a.m. till 9, and then from 9 a.m. through till 4, do video conferencing or telehealth, and then from 4 till 5 or 6, take more telephone consults. And a telephone consult was usually from a GP with a question, you know, some advice. So that's sort of how I ran things. And I think each of the Indigenous physicians will want to run things a little different, and that's great, as long as it works for them and the patients. So this is more of the same, consult notes, etc., onto the EMR. Then evaluation. In the past, we've evaluated the diabetes program for the general population. And of course, we did the usual kinds of things, you know, process, patient providers, patient outcomes, and dollars, the quadruple aim kind of process. And for this, then we will be doing cultural safety and traditional and Western approaches, and we have several mechanisms for that. But you'll see on this next slide, we are going to be using some of your wonderful evaluation processes on the website from New Zealand Telehealth, are templates on exactly how, and even the questions to ask on how to evaluate your telehealth program. And it's much like the quadruple aim of getting input from all the providers, physicians, nurses, nurse practitioners, dietitians, clerical staff, anybody who has anything to do with it. The patients, obviously. There's several ways that can be done. And the way I like to do it is basically hand out simple questionnaires to everybody during a certain period of time, rather than choosing. We have a peer review system where you get patients to review you as a physician, and some people are inclined to pick and choose the patients that they give it out to, and I'm inclined to just give it 25 one right after the other, because that way I'm going to get hopefully a little less biased input. But so yeah, with a great help from your great gurus in telehealth evaluation, we'll be doing that kind of process. And in terms of cultural safety and inclusiveness of the target audience, we have a Canadian evaluation called Ways Tried and True. And that asks about, you know, were we involved in the conception of the idea? Were we involved in the processes of setting it up? And those kinds of processes. And then it also goes into patient and provider experience or acceptability, satisfaction, and then patient outcomes. So that's consistent actually with this Maori evaluation framework, and I can't pronounce it, I'm sorry, but it's the Hipikaganga Waijura implementation framework, and that deals again with a lot of the the spiritual, the physical, mental, and emotional aspects of health, and how that fits, how this project fits with that. So it's kind of exciting to be able to include that. We've already had all the concerned individuals to date do one version of the ways tried and true, and we scored fairly well. We have no outcomes yet, no patient outcomes yet, so we couldn't get full score. But on a score of 24, we got 16. So many of the measures that were about the inclusiveness were highly rated. So we felt very proud of that. And to finish off, I'd like to acknowledge the passion of some of the people that I'm working with. And this is only about 1/3 of the people that we're working, but Dr. Kurtz is that PhD nurse who is Métis. Jesse Nyberg is our elder advisor. Terry Aldred is our Indigenous physician in the North. And Clayton Reynolds is an endocrinologist, a Caucasian endocrinologist with 15 years of extensive telehealth experience. He's an amazing guy. He's about 74 now, and he's still practicing like crazy. And then Susie Wilkinson is with the Interior Health, and she's committed. And Carol Camille and Kelly Lirondelle, Rosanna McGregor, Vicki Michaud, Edna Turbasket, and Patricia Wilson are all the executive directors of each of the Friendship and Métis centers. And their passion is insurmountable. It's absolutely fantastic. And this wouldn't be happening without them. So thank you for listening. I talked way longer than I thought I would. Any more questions? Or
I don't think my observation is how much community involvement you've had, and you've really encouraged that. That's taken a huge amount of resource and time and thought to get that really genuine community involvement. That's my big takeaway.
Oh, well, thank you for that. And really, to be very honest, we've been working with these communities for probably 8 or 9 years in building relationships and getting community research agreements going, because I imagine it's similar with Maori folks in your country, that they've been researched and people go into the communities and they do all sorts of good things, and then the funding is gone and the project is gone, and people are sometimes worse off. And so many of our Indigenous community members are just, research, no, go away. And so it was important that they understood that that's not going to happen here. It has to be your program. You own the program. We're just helping you. That's it. So thank you for seeing that, because of all the outcomes, that's the most important, is the trust is built.
Thanks very much. It seems like, from my perspective, there's quite a lot of similar barriers and facilitators than we have experienced in New Zealand. But I wondered, one from my research perspective, is the difficulty is with embedding the service and making it business as usual. And I just wondered whether you have any comments around what you foresee the difficulties for you to be able to embed it as usual practice.
Well, I think the primary difficulty, is pulling it out of the traditional healthcare system. And we're going to be relying, for example, for administrative assistance, we'll be relying upon the person at the front door at the Friendship Center. And they're not used to, they're used to, as I mentioned, holding programs, but not scheduling individual people, or keeping track of individual people. So although I've sat down with the executive directors and gone through, how would this work? How would that work? If I walk in walk me through what would happen. And so we talk back and forth. But I still think when it comes down to it, that that's going to be a challenge. And I think we'll have to do a few mock clinics, pretend clinics. Maybe I'll pretend to be the patient, and maybe a few group clinics, a few group visits might be a way to do it. Another challenge will be recruiting patients, and I'm making patients aware, making GPs aware. In the smaller communities, that's going to be easy, because I'll go around. Often the GPs work in the same building, or I can go around, knock on doors and make people aware. But some of those patients that don't have GPs, how do I make them aware? Communities are telling me that there's a bunch of elders lunches and family gatherings, things like that. So the communities will tell me how to recruit people. But one thing the communities told me, I asked them, well, if I were to hold a screening session, so if I were to say on, Wednesday afternoon or whenever the community says, I'm going to have my blood pressure machine, I'm going to have my finger poke for your hemoglobin A1C and urine test and, a lipid test and those kinds of things. Would you like to come to something like that? And we could have a little educational session along with it, and then let them know that if you have diabetes, then come on into the clinic. And again, at that screening session, we could demonstrate what telehealth might look like. So I think there's going to be difficulty running the clinics and then recruiting the patients. The no-show thing, or forgotten appointments, it depends. I seriously doubt that the administrative assistant in each of the friendship centers is going to have time to call people. Reminder calls the day before are great. They don't always work though, do they? That's up to us to make the clinics comfortable and culturally safe. And I think each patient needs to be asked afterwards, how did it go? And what could we do better, kind of thing. What else is gonna, well, yeah, I guess those are the main things I see as being difficult. Technology, well, we better make sure that more than one person in each friendship center knows how to operate the Polycom. It's easy, but still people are scared by it. So even simple technology. So we need to make sure that we spend enough time making people comfortable. I think that's probably, can you think of any other things that I should mention?
Some things that have come up in my research is provider reluctance. So actually getting providers on board who are keen to change the way in which they practice. Yes,
and I think that that's really important. And I figured Andrew said there'd probably be a few questions around that. And I think that that's a challenge that, I would almost treat that in many ways the way the community interaction has been to the past is to sit with the physicians and demonstrate. I think, and again, we're funded by a grant, not by big Ministry of Health money. If we had, dream come true, big Ministry of Health money, then there would be somebody available to train everybody and make sure they're comfortable with it, reduce that level of anxiety, and also provide a system, be that a computer or a cell phone or one of those little Cisco things, to make it a bit easier. But I think that that's another, thank you for bringing that up, because I think that that's going to be an issue. And it may well be that providing education, videos, webinars, those kinds of things, but face-to-face. And that's why I'm going to go visit all the communities. And also get feedback from the physicians who are doing it. How do they fit it into their day? And is it going to affect their practice? Because we can't have incomes dropping as a result. So being able to get sessional fees, that kind of thing, organizing for that is important, because they're going to be, in the beginning, there won't be many patients, or there'll be, even if it's up and running, there'll be no shows or whatever. So I think that's huge. That's a huge question. And if you have any ideas, any answers, I'm all ears.
No answers, but very similar issues in New Zealand, I think.
Yeah, I think so. For sure.
Oh, thanks very much. It's nice to hear your story.
Oh, well, thank you for attending and asking very good questions, for sure.